The following is not meant to serve as medical advice. It is merely the story of my own journey and learning process. All the Unexpected, Season 3, Episode 7, Holistic Healing. Welcome to All the Unexpected, Season 3, Episode 7 already. And I have the absolute distinct pleasure today of being joined by Dr. Rebeca Segraves, who is a doctor of physical therapy, physical therapist, the founder of the Enhanced Recovery Wellness Network, and the CEO of the Pelvic Health Network. And she is here today to discuss with us physical therapy after birth, things that we can do as both patients and providers, and to really just talk about health, our pelvic health in general, and sort of ways to empower families. So thank you, Dr. Segraves, for joining us today.
My pleasure. Thank you for having me.
Did I miss anything in the introduction?
Not at all. No.
Okay.
Glad to be here.
Thank you. So maybe you can give us a brief overview of the work that you do in the space of maternal health, in the space of pelvic health, and kind of how you maybe came to be doing that work.
Sure. It actually, a lot of my background has to do with outpatient women's health in just general. And so I would see moms when they were pregnant, preparing for birth, and then shortly after giving birth. And that was a lot of my early profession. But then in 2020, I started treating in the hospital, and I was exposed to actual, labor and delivery, and actually being able to treat moms within 24 to 48 hours after cesarean section, and just teaching them how to protect their incision, how to get out of bed. And I really didn't realize how uncommon that was, at least in the United States, for a woman to have a major open abdominal surgery, have to go home, take care of her baby. But yet down on another unit, we were treating people after a small surgery, like a gallbladder surgery, and teaching them how to get out of bed. But we weren't doing that with moms after cesarean section. And so in 2020, my eyes were kind of exposed to the disparities in maternal health. And so I started a lot of work of just training other therapists to treat this population like they would anyone else that comes into the hospital and wants to recover really well so that they can do life when they return home.
Yeah, and so I just kind of want to circle back to something you said there. So as someone who has had a crash C-section, so I don't know if sort of the story of how All the Expected came to be. I'm the mother of a now 3-year-old who was born at 26 weeks after a cord prolapse and a crash C-section, and so have experienced it firsthand. And when I kind of started following some of your work, it was light bulbs for me too, because I said, well, that's not what happened. And especially in 2020 when we were doing virtual follow-ups for even major surgery. And so one of the things that you did mention there, though, the idea of a C-section as major abdominal surgery. And I just want to touch back on that point for people who are just really not aware of what we're talking about.
Absolutely. Yeah, I think the term cesarean section really separates it from other open abdominal surgeries. But when you actually, are informed that a cesarean section involves nearly 7 to 9 tissue layers being separated just to get to baby. And I now teach courses where I'm actually having my students watch a cesarean section. And the Baby Center is this wonderful website that actually has a story and a video of a live C-section being performed. And I think it's just important that maybe not for moms, if you don't want to see that, that's okay. But at least for anyone who's calling themselves a health provider, definitely a physical or occupational therapist that prioritizes function after surgery for other patient populations, you should know what a C-section is for sure.
Yeah, no, it's important. And so I think it was an interesting point that you made to say that the kind of work you do and the way in which you see moms is not common. And so maybe can we speak a little bit about what the average care actually looks like, and what the gap between what's happening now when most people have a C-section and what ideally should be happening?
Sure. Yeah. So I have had probably extensive experience with most post-surgical rehabilitation. And so that's anyone who like chooses to go into the hospital. So we call that elective procedures, and they include the birthing population. And so if I choose to go into the hospital for a knee replacement or a hip replacement or a spine surgery, then my medical team or my surgical team automatically orders an occupational therapist and a physical therapist to help me recover, to help me walk, help me get out of bed. If I don't have a hospital bed at home and I know I'm going to not use the hospital rails to get up and moving, then that person will help me do a different technique to get out of bed so I'm not pulling at my incision. For someone who delivers a baby, they're not given those services. And there's really no other reason other than there's a disparity. People who have babies or elect to have a baby in the hospital, choose to have a baby in the hospital, are treated differently than the general patient population. And I saw that early enough in my career before it got too far, before I started to speak up about it. And I said, this isn't right.
Yeah. Yeah, no, it's an interesting sort of thing. And so for those who would say, okay, I've elected to go to the hospital, right? I'm going to do this way. I think the vast majority of C-sections tend to be at least planned or with some sort of preparation, right? And so the kind of you knew 2 minutes before in my case is incredibly rare, just to let people know. Um, and so what are some ways that from a patient perspective they can ask those questions and sit and ask, are these services available? Are there ways for people to kind of on the patient side of things prepare themselves and be able to ask these questions?
Yeah, so from a patient perspective, I usually will tell anyone before they walk into a hospital, while they're still doing post or prenatal care visits with their OBGYN, to ask for an occupational therapist or a physical therapist before they leave the hospital to make sure that that person is on their care team. And that's now the education that I give people just going into the hospital. We give that education to someone after, before a hip replacement, we call it prehab, and we're already preparing them for the 24 hours after surgery. And so we're generally just making sure, I think right now our organization is just focused on public education because the providers know that those individuals are in the hospital. They're ready and willing to help people. We just need to get the information out to people that you can absolutely ask for this service.
So yeah, to circle back to the idea of public education, and so I'd like to talk a little bit about how you are tackling that and what sort of was the genesis. And I'm assuming that's more with the pelvic health network than it is with enhanced wellness, or is it all sort of one animal these days?
Yeah, Pelvic Health Network is more of the media arm. And so I think after I became a doula, I realized, well, who's mostly integrated in the community? And I would say that out of all birth providers, people know to go to their OBGYN, if they're pregnant, if they want to, give birth in the hospital. But I think kind of the next like go-to person has been doulas in terms of who shows up in the community the most, who's like embedded in the community, who is boots on the ground, spending, so much time with people. And so I decided after, degrees, licenses, certifications, all of that, nothing would probably really help me more be able to communicate and educate people than doula training. To me, that was like the top of the top because it really allowed me to see both sides of it. I knew what the surgery involved. I knew the stats about postpartum hemorrhage and all the yucky things that we talk about, it's kind of driving our maternal health outcomes. But I didn't really know, how do I get this information to people? Like as a provider, you're not really, it's going to sound crazy, but you're really not taught and communication skills from the perspective of the patient. We say that, but when in reality, the fact that we're even having this conversation shows that we really primarily practice hospital-centered care. What's best for the hospital? Is it profitable for the hospital to give occupational and physical therapy to someone, even though we know it's going to help them? Is it going to take away from our profits? That's really the conversations I've found myself having. And I found, oh my gosh, this is not really getting that information to people. How do I do that? And so I started to work with doulas, and I just realized, well, let me teach doulas. If your hospital is going to just do a virtual visit for a woman of color, I had to finally see 3 women of color be readmitted back to the hospital with cesarean section infections because the camera couldn't pick up that they had a raging infection under their melanated skin. Their doctor was trying to diagnose a cesarean section as being healed. You're good to go. You could start moving a lot more. And they didn't realize that that infection was brewing underneath that melanated skin. And so those are the kinds of things that I need to teach the public. And I'm teaching the public now through community, efforts, through a lot more through social media, is just to look at your incision before you even leave the hospital. Advocate for yourself. Make sure they give you an abdominal binder. Make sure they're teaching you how to get out of bed that looks like your bed at home, because you're not going to have a hospital bed to hold on to the rails to help you get up and moving. And it's just that basic education that we would give to any patient after an abdominal surgery that's just not being given to someone after birth.
Okay. So a little bit mind blowing there. I want to circle back in a second to talk about are we even talking about this gap of healthcare with regards to an increase in virtual care and camera sensitivities and skin pigmentation, because that to me seems like a Pandora's box. And so if we're talking about trying to diagnose things and cameras don't necessarily have, and we know this for a fact, given, the sort of, and I'm a bit of a historian, I am a historian. And so I get deep down into the sort of the development of film technology and what it's always been sort of based on its meter and the kind of, so let's not get too far down that route, but that's an interesting thing. And so I wonder if anybody has really been taking a look at the gap in healthcare with the increase in sort of virtual visits and what that means when you've got cameras and technology unable to pick up certain details in different skin tones, because that is a huge piece. And so I think we'll have to maybe, I don't know, circle back and do a much deeper dive into that. But you brought up something that I want to make sure that listeners understand and know. What do you mean when you say an abdominal binder, and what is that, and what function does it have in the case of a C-section?
Sure. So any surgery usually is given a wrapping for compression. And so if I'm seeing someone after a knee replacement, they've had a wrapping or a bind, if you will, or ACE bandages that's been wrapped around their incision, because we know that compression helps with swelling. When you have swelling, well, you're pushing out on that incision and you're actually causing it to open and not stay closed. And so an abdominal binder is just something that we were using it on gallbladder surgery. I mean, anyone, like after robotic surgery. My father had a colon surgery. He was diagnosed with stage 4 cancer a few months ago, and he had this colon surgery. And so I brought him an abdominal binder. So anyone who's like feeling swelling or bloated or a lot of pressure really benefits from compression. And so treating on the maternity unit, when I saw that, like, those binders were just sitting unopened in packages on the counter, I was like blown away. Like, we are not even opening, like, mom's not getting out of bed and just knowing what this is. Like, why are we not opening these packages and showing them how to use this for compression? And why is it 2 days and they haven't had compression? Like, it was just mind blowing to me. It was just like, I felt like I was going back in history when I started treating on the maternity unit. Like, this was 1950 or something. Like, it was all of the best practice that I had been taught as a rehab therapist for post-surgery was like out the window on the maternity unit. So abdominal binders are just wraps that you use after a major surgery, especially where your belly was open. It's not a robotic surgery to get baby out. You actually have to open layers of your skin, your muscles, your fascia, and then your uterus, and then close all those layers back up. You want something that holds everything in while you're moving because your muscles are not firing um, at all within the first few hours to days. And so that compression helps to keep that swelling from pushing out on that incision. And it ensures that you're less likely to open any of the layers underneath the skin or the skin itself where you would actually see it. Sometimes you'll open an incision and you won't see it. And camera technology, I can go all on that because those three women of color who had to return to the hospital just in 2020 alone, when we were primarily depending on camera technology, we were doing a lot of telehealth through COVID. That's where I started to think, is it our cameras? Is it the technology that's never been calibrated or configured for melanated skin that's also the problem? Like, how are they not picking up that this person was having an infection and now it's gotten into their blood and now they're dealing with sepsis and sickness and all of that kind of stuff that's affecting their kidneys? All this stuff I was thinking about in 2020. And so I realized it's not that we're doing something differently as rehab therapists, it's that we have to communicate it so that everyone views the maternal health population like everyone else that we treat. They don't treat them differently. There's not a disparity there.
Yeah, a lot there. Don't want to make your head explode, but I'll tell you, nary an abdominal binder at site in the city of New York at one of the nation's premier teaching and maternity hospitals. So, as someone who was there for 3 weeks before I gave birth in a crash C-section, and spent 109 days in the NICU, I will not say that I saw a single binder suggestion. And it's interesting, actually, because that practice of the binding or the closing is actually sort of one of the most ancient things in the world, right? So that if you look at Ayurvedic medicine and you look at Chinese medicine and you look at West African postnatal practices, right? There are these, the Mexican 30 days of quarantena, right? All of these sort of things that, we look at all over the rest of the world in ancient non-Western practices of medicine. There is some sort of closure and binding and a use of that. And so not only are we sort of not following best practices of Western physical therapy and the science that we adhere to, but the rest of the world or the rest of human civilization seems to have understood this as a kind of essential practice, regardless of the way in which you give birth, right?
Absolutely. Absolutely.
So interesting. Okay. So I think there's a lot there. Yeah, I'm sort of now a bit, I guess, chomping at the bit to really dive into this whole camera thing, because and also I just think a side point, because I had a similar situation where they said, okay, we'll do this virtual visit, and I said, well, things that I'm not putting on a camera, I don't know who's in your office, I don't know who has access to your videos, I don't think that in a space where a lot of people experience trauma of different sense, that it's a really, kind of effective way to do things for people. I think you have, there's a great deal of birth trauma when it comes to maternal health, right? And then you're talking about just sort of a level of invasiveness that I think is also not really being addressed.
Oh, absolutely. And I think for the most part, a lot of practices hopefully have like not gone the route, at least in the postpartum period, to just primarily depend on cameras. But because of where this work started in 2020, because that was my experience, I knew that one, we needed to educate moms as early as possible before they actually went home and encountered a provider who wanted to assess whether they were starting to have an infection around their nipple, right? Which is mastitis. Starting to have an infection around their cesarean section, starting to have an infection or a problem around their perineum, which no woman would want to put on camera, right?
Yeah.
And so that's kind of where I found myself, is that where we were depending on these things in 2020, it was already eye-opening that they weren't configured for us. And the care wasn't embedded in ancient practice that we've known for the span of human history that works, whether it was binding, whether it was wound care, whether it was resting, whether it was making sure that someone could handle the challenges of their own environment. And that was another thing I wanted to mention before, is that on the maternity unit, people weren't being asked where they lived. Almost every single unit of the hospital, it doesn't matter if you had open heart surgery or open abdominal surgery, we would ask where you live. So if you had stairs you needed to negotiate, we would practice those and make sure your blood pressure didn't skyrocket. And in the maternal population, within the first 6 weeks, we still have this issue called preeclampsia, where mom's blood pressure will skyrocket, and we're sending her home to negotiate a second level walk up with a baby in tow without asking, do you have that support? Do you have stairs at home? Do you have another way that you could actually do this? And so again, it just brought me back to like the stone age of practice, of medical practice.
No, I mean it's such a gap. I think of my own dad who had a double knee replacement, or me 22 years ago who had a metal plate put in my ankle, right? And I just think about, to the point of I was sick of the physical therapist, right? To the point where they said, stop bothering me, right? I'm not doing this thing. We're not walking, and we did stairs. And I remember being in the hospital, stairwell with my ankle crutch, and they're saying, well, this is how you would, if the handle was on the right, this is how you would do the handles on the left. And I'm thinking, as you're saying this now, back to when I, gave birth, and the only time I remember some sort of anything was when they told my husband to carry me in my arm and walk in a circle around the ward twice, come back, you didn't fall down, all right, good, see ya, never. Right. And so yeah, like it's actually sort of mind-blowing when you put it in that terms. So we will, replace your knee, we will, give you a micro, I think my mom even just, arthroscopic surgery on a rotator cuff. And you had 6 weeks of physical therapy, and she went there twice a week, and they sent her home with the exercises. Right. I think about all these other situations where I physically have either experienced or seen other types of surgery, and we're doing this for everything else. And my question is, and I don't know if you've got an answer to it, what is the why? Why do we have this disparity? What's going on?
I wrote a manual, and I even tell people I didn't write a book, I created a library. And in my library, I still can't find the answer to why OBGYNs are now becoming the only specialist who's not using rehabilitation therapists on their team. Cardiologists have had us on their team for decades. We see someone immediately after a heart procedure. Orthopedic surgeons have had us on their team. I've worked with oncologists for 5 years. I primarily just saw women after a mastectomy or hysterectomy associated with cancer before they would have other invasive treatments like chemotherapy and radiation. Just automatic. I don't have the answer to that. I don't know why OBGYNs are not utilizing us. And I have to just give them the benefit of the doubt. Maybe it's education. And so that's why I do what I do. I'm willing to educate, but only so much, because if it's educating them, but then it stops with them and it doesn't get to the community, I realized I needed to really change gears. I needed to talk to people before they actually were in those situations where they were neglected, because that's really what we're talking about, is patient neglect, people neglect in a very large area of medicine, obstetric practice. The cesarean section alone, the cesarean section is the most commonly performed major surgery in the entire world. Not just the United States, the United States as well. It's the number one surgery performed in the United States. In the entire world, it ranks number one. And I realized this is an issue of neglect.
Hmm. And just for those who are unaware, the rates continue to increase year on year, right? So we're performing more C-sections year after year after year, and the rise is exponential. That is a whole different conversation. But one of the things, and I think to circle back, the disparities between maternal health and women of color, and so are we seeing this sort of snowball of outcomes be worse in certain populations, and what have you seen with regards to determinants, and why that's the case, and what's really going on there?
Yeah, and those statistics that you're referring to, right, where women of color, Black women specifically in the United States, have such larger outcomes of maternal, not just mortality, but morbidity. And so morbidity is not really talked about as much. But morbidity is where my wheelhouse is. It's kind of my sandbox, right? I deal with morbidity across diagnoses, and those are short and long term complications of anything, of a birth, of surgery, of anything. And so, complications that could impair someone's function or ability to thrive or work or be in a relationship, uh, have intimacy, whatever it is. That's kind of what rehabilitation therapists are called to address after the fact, right? But because we have such large numbers in the Black maternal health population or Black women's health or pelvic health issues, that's kind of where I started to move, was upstream. How could we prevent those things? And I realized my degree did not separate me from someone who was white who did not have a college education. Like if I walked into the hospital as a Black woman with X and number of certifications or degrees, I have a doctorate in physical therapy, I have a certification, I'm board certified, all of this, I would still have those deplorable outcomes of Black women compared to someone who was white without college or high school education, whatever it is. And so that's where this is getting into root causes, systemic injustices. Like we have to talk about it. We have to actually educate the community about what they could potentially face and how to actually give them the tools before they even put themselves in that situation. If that's their only option to give birth in the hospital, here's what you should know. Here's how you advocate. And a lot of our training is really just resistance training, if you will, arming yourself so much with knowledge that you're not put in that position of being on the defense. You're on the offense every time.
Yeah, no, there's a lot to unpack, and I think we could probably talk for hours on that. I think that's a really big piece of it. I remember I started following your work because I had gone to a webinar that you had, and I know that there was a guest who was talking about the legislative advocacy of this, and some of the work that's being done to kind of, so we've got, the end of community education, which I think is a huge piece, empowering people to know what to ask for, what to look for, but what is some of the work that's being done surrounding that? And maybe you can kind of share with our listeners, because I think that's a really important piece. So what are people doing to kind of ensure that some of these things are actually enshrined in legislation, and kind of that aspect of it?
Well, yeah, actually, there's a lot of different pieces of legislative efforts. There's from the physical therapy side, there's a big push for Congress to approve, at least for individuals who have Medicaid insurance, that they are provided with at the time of birth. So it's something that's not necessarily occurring during pregnancy or prior to that, but at the time of when they start lactating, and that's immediately after they give birth, they're provided with pelvic health therapy services or pelvic health services. And that can be a number of things. And so I think that that's an important piece of legislation that's coming to before Congress. But we also have other efforts being made to make sure that those individuals are provided with information during pregnancy as well. There's an organization based out of Denver, Colorado called the Elephant Circle that is the founder, I believe, is a lawyer as well. And they really kind of actually help fund the people to actually get services like doula services while they're pregnant during the time that they're actually giving birth, so that we're not doing so much of this on the back end. And that's kind of where my work is going towards, is not waiting until someone develops pelvic health issues, incontinence, prolapse, all this kind of stuff that we don't want to deal with when we're recovering after a major event already. My work is, well, how can we equip people with just monitoring their own vital signs so that they are not at risk of, eclampsia or preeclampsia before they even walk into the hospital. And so I work with an organization called Operation Mist. And the founder of that organization is Dr. Catherine Sylvester. And she actually uses Garmin smartwatch technology to help people monitor their vital signs, if you will, so that if they're not feeling the best and their providers are saying, you're okay, you're fine, she could actually match that data with other metrics that she's measuring. And so that's just really empowering people before they get into the hospital situation and the institutional situation to have enough data or have enough autonomy over what their body is telling them while they're pregnant, so that we're not seeing this continued increase between Black maternal health and white maternal health and everyone else.
Mm-hmm. No, I think, and that's a big piece of it too. The idea of self-advocacy being having a role, right? And playing a role in it and saying, if you think to yourself, I don't feel right, something feels off, this is not okay, being able to not just defer to a medical professional that's telling you, oh, well, you're just fine, right? So I think that's a really big piece of the education. It's really important and really empowering to say, hey, you can take this piece into your own hands, right?
Absolutely. Yes.
Oh, that's a big thing. So I want to kind of talk a little bit about the not worst case scenario, but let's say someone is saying, all right, well, I didn't get the PT at the time of birth. And, here I am 2 years later, 3 years later, and, I still have pain and I still have limited mobility, or I still have all these other things. Is it ever too late for someone, or do you tell someone in that position, no, you can still go back and see somebody? And there is sort of, what do you tell someone? Is there ever a situation where it's too late, or can you always sort of try to tackle the problem, I guess is the question.
Oh, absolutely. I did this myself. I always think that it's probably anyone's best interest who serves people, who's in the position of serving people, to constantly reevaluate what they could have done at the time they had a role in that person's care or that person's journey. And I went back and I started to look for clients of mine that I was their physical therapist, and I just wanted to have an honest conversation. I did something like this just very recently, podcast style, recorded and put it out so that people could see it, of a client that I treated who was a mom of two, had a cesarean section, babies ended up in the NICU, and she was alone within 2 weeks, having to care for her babies. Like, just felt like she was not given the information. And at the time I treated her, she was 3 years after her C-section, having all of these symptoms, pelvic floor symptoms, issues like that. And even at the time, I neglected to talk about how important it was to massage her scar. She was 3 years out. I didn't think at the time when I was treating her, even with everything I know now, I'm kicking myself. But then I thought how important it was to go back and have that conversation, because when she told me she went to see someone else, because I wanted that honest conversation, like, what happened when you saw another therapist? She said, well, it's so important to massage your scar even 3 years later. And I just absolutely loved hearing that feedback and learning that there's never a point on someone's journey where it's too late. You will always probably feel something is off. Major open abdominal surgery, if you actually ever watched it as the person who's gone through that experience, they are shifting so many organs and tissues around that it's beyond us to think that they would get it right back where it's supposed to be. And so for things to feel off years down the road, it would be abnormal to find someone, or it unfortunately is probably too normal to find someone to say, oh, that's normal. That it's not normal. Is nothing's about that experience is normal. And so there's always something that we can continually work on, improve, and learn from as providers ourselves, because I think too few of us don't realize the amount of change that occurs to the body in such a short period of time. And the best thing that we can do is just listen to people, listen to what their journey has been over the past several years. How has it affected their overall well-being? How's it affected their fatigue? How has it affected their capacity? And if we take time, so much time on those few questions and just actually hear what's going on, we'll find something that we can really focus in on so that they can feel that they've mastered that one area of their life that's really bothering them. And for her, it was this pressure. She felt pressure all the time and she couldn't place it. And it was massaging her C-section scar 3 years later that resolved it.
Hmm. Well, no, that's a huge piece. And I can't tell you how refreshing to hear from the perspective of a provider that the effort that you've made is really to remove the hubris, right? Really to remove the sense that, well, I knew everything, I did everything, this must be a them problem, right? And I think that that is such a big piece of it, right? Being able to sort of step down from the pedestal, right? Step away from all of the titles and the degrees and everything and say, you know what, there might be more for me to learn. And there might be more for me to hear and learn from that person, right? And I think that's such a big piece in a lot of the sort of professional and even myself as a teacher, teaching profession of this, well, I know everything, right? And I can't really stress that. And so for the people that are listening to this that are on the provider end of this, that's to me such a beautiful piece of this, that you're saying, you know what, I can go back and continue to learn and continue to revisit things and continue to sort of reevaluate the way in which I do something, and thus making myself a better professional, right? And that's just, yeah.
Yeah. I You said something that like kind of struck a nerve. Um, Back just a few like kind of I guess moments ago when we were talking about best practice, and I realized like what we've historically based that on in Western medicine was what was chosen to be published in journals. And that was something that probably I think originated in the 90s. I did a talk on this and I had to like find, well, what was that hierarchy that we decided this is evidence-based practice, this is how we divide all of these things that are either not well founded in evidence versus things that are systematic reviews. And there was a model that came about um, post 2014, 2015, somewhere around there, that actually involved the person's experience in terms of best practice. Like it was what was in journals, the clinician's expertise, and then the patient or the client experience. And it put it all on this pie chart where everything was equal. Every piece had a third. It wasn't this hierarchy of what was chosen to be published in this journal somewhere. It was actually on a pie chart where the person's experience mattered just as much as the clinician's expertise and as what was published in journals. And for me, best practice for me going forward now is going back to people's experiences and seeing how could I have changed that? What could I have done differently? What did they find that actually worked? And using that to inform future practice. That to me is the most important thing I could do in my career. I'm not waiting for someone else to come up with an article telling me what we should be doing with moms after cesarean section. I'm going right to that person. What would you have liked to have changed? What would you have liked to have known? And that to me has been informing best practice, at least for the time that I've been doing this work since 2020, primarily with the maternal population. But before, it was just women after procedures that were also ignored.
Mm-hmm. Well, that's a huge piece. And it shouldn't be so controversial, right? And it shouldn't be so new, right? So that only, we're saying essentially, only 9 years ago did we say, oh, maybe we should listen to patients, right? So there's a moment there where, there's such a stopgap, or when you see some of these studies and they said, I remember I was reading something and someone gave, $1 million to the NIH to do a study that said that, Black people feel uncomfortable sometimes in the hospital. And it's like, well, you know, at the end of the day, we could have all just raised our hand.
Did you need $1 million, right?
It just like it's just it's mind blowing sometimes, and now it's official because you put it in a study and we've all published it, and you're sort of just sat there sometimes, and I do a lot of research and for the documentaries. And then if you want to even get into the history of things that have been published in journals, and, I went down a rabbit hole of 19th century New England Journal of Medicine articles about, the different humors and how my bones were meant to actually look different and all these sort of things that we've enshrined in medicine to a certain extent. Like, let's maybe take a step back and think that we might not have always put the best practice things in journals, and that there's something to be said for that. So there's so many pieces to this, and I think it's really important that is a crux of what's informing the work, and as it should be, right? As the sense of, and even when you look at the notion of best practice, it's a lot like teaching to the middle, right? It's not going to necessarily be the best thing for everyone, and I've been recently on a rail against hearing the word protocol. That's great, okay, but hi, here's a person, and why are you doing this? And I've pushed up against, and we did for the entire 109 days that we were in the NICU with my daughter. And I'm sure a party was thrown when we left, and they said, oh, these people with their questions and their articles and their research, are they finally going home? Because at a certain point you have to ask, okay, well, why is this your protocol? Why did you adopt this particular best practice, right? And I think some of these questions of how did we get to this consensus is a really important thing. How did we decide that this is what we do or this is what we don't do, right? And I think people aren't really asking those questions, especially from a provider point of view, right?
No, they're not. I just had to, I have to like just speak on the protocol part. I mean, because again, you're speaking to my bones here. We recently had a mom that one of my students, if you will, saw, and she, again, blood pressure was coming up, heart rate was coming up, but the protocol, right, is to have people either fit into the certain parameter. The nurse will not do anything, doctor won't do anything until their blood pressure reaches X, Y, and Z, 140/90. Well, we're completely negating someone who might be an athlete who already rests in the low 100s to 60s, over 60s. And for people who don't know what I'm talking about, normal blood pressure kind of cap that we want to see. Like, we don't want to see your blood pressure get higher over 120/80. Well, the protocol from maternal care would be that a high blood pressure, too high of a blood pressure, maybe 140/90, right? Or even higher, 160/90 or so. And it just gets more and more. But yet, if you're an athlete and you already are in the low 100s/60s and you're raised to now 120/80, or you're raised to 130/90, that's already too high for you. But because we're kind of constricted to these protocols, which have been published in these very respected journals, we're now neglecting the care and the needs of someone who could be an athlete and who may actually be showing us signs of distress before they get too far. And so we're losing mothers to protocols. And that's so controversial to say, but our protocols are what's killing us, not necessarily my skin color, because that's kind of the default.
Mhm.
Well, are you a Black woman? Let's use that to then drive medicine. And I'm saying this publicly, probably for the first time. I worked in a hospital that practiced race based medicine because of protocol. And so if I were a Black woman going to that hospital, I would automatically be put on Pitocin, which is a synthetic agent, for 8 hours after I gave birth versus a white woman. And when I learned that protocol in 2020, I was appalled then. I'm still appalled now. And I'm now just speaking about it, and it's 2023 that we're recording this. But the protocol was that if you were a Black woman, you're given Pitocin for 8 hours. If you're a white woman, you're given Pitocin for 4 hours. Well, why was that? Pitocin was meant to ensure that a person would not continue to bleed. It was meant to prevent postpartum hemorrhage. But what people need to know is that naturally, when you're breastfeeding or bonding with your baby, you have oxytocin that's coming down from your brain. It's contracting your uterus and making sure that you're not bleeding or continuing to bleed. When you're given Pitocin, the synthetic version of that, it actually causes the blood pressure to rise. And so we were having Black women on Pitocin for 8 hours, 4 hours longer than normal considered a white woman. And their blood pressure was elevated over that 8 hour to 12-hour period that we were monitoring them to see if it was safe to get up and moving and start walking and do other things out of bed. And so I say all of that because protocol in and of itself is an injustice. It's based on white skin, it's historically based on European features, and we've been using it to direct care of a population that has drastically higher rates of mortality and morbidity in this country and beyond.
Yeah. Yeah, and I think part of the understanding is really understanding the history and really looking, and especially when it comes to obstetric medicine, right? And so, once again, the historian in me has gone and lived in the rabbit hole, not even, dove in. And there's so much there, and there's so much with regards to what we call the standard of care that to this day, I mean, the indicators of kidney function that have got the weighted averages, right? The cardiac. I mean, there was a story I read recently of a medical student who discovered the discrepancy in one of the cardiac exams that was weighted for race historically, that no longer made sense to do that, and was actually given all of these misdiagnoses. And it was a medical student sitting there just kind of like having a moment and listening to this whole thing and sort of just meekly raising his hand. And I forgot what hospital it was at, but one of the major teaching hospitals, and they literally had to reevaluate all of protocol because somebody was sitting there for once and critically thinking about it and saying, well, but that doesn't really make sense. Like, so then wouldn't you, like, if X were true and Y were true, wouldn't you actually end up having worse outcomes because you're sort of weighing it this way? And they all sort of, in a room full of experts and teachers and pressers all kind of went, oh, ooh, okay. And it was this moment. And so this idea that critical thought with regards to how did we get here, right? Sort of, deep analysis of saying, well, maybe there's a flawed origin in the basis of this protocol is somehow very controversial, right? It's somehow kind of like, let's not rock the boat, right? Like we're sailing along, but the bottom line is we're not sailing along. People are drowning, right? And so, it's such a big piece of it, and somehow so marginalized in the actual discussion of all these topics, right?
Right. I think it's a powerful lesson in the humility of all those experts in the room. The humility that must have had to have a medical student point out something that people just took as dogma.
Mm-hmm.
you
Mm-hmm.
know and that's where it really is. It's like, are we allowing people to be the Galileo? Are we incriminating them for the rest of their lives and then finding out years later, oh, they were right? Or are we allowing ourselves to be humble and saying, okay, we don't know everything. Not everything is just concrete written in stone. We're willing to change and reassess this. And I think that that's kind of what drives my work is why do we treat the maternal population differently than everyone else? It just starts with a question. I'm just wondering, really. And I am. I mean, genuinely, I do wonder. I mean, I've been practicing post surgical rehab, since 2009. And I just wanted to understand why are they so different? And it just starts with a question.
Mm-hmm. Yeah, no, and it's a great use of the word dogma. So are we, adhering to a sort of established, static, dogmatic practice of medicine, or are we practicing science, which in its definition should be continuously evolving and continuously, transformative in the nature of once you learn more, do different, right? And so that's, I think a huge gap right now, and there are, there is a movement towards patient-centered care, and I had a lovely discussion with a gentleman who was a dean of medical school in Australia, and he was talking about this and the idea that and he brought up a really interesting point, and he said the rapid rate at which information is advancing, right? So that we've got this kind of exponential rate of collective information because of just the nature of technology, right? That there's going to be constant development, constant information. He said the average physician who goes to school within 6 years of them leaving school, 95% of what they learned is obsolete because it's just rapidly evolving. And he goes, and so that in the future, you're not going to be able to not rely on the patient who read the latest thing and did the research and informed you, and that dialogue has to be open. And the medical student who maybe read something somewhere on the internet that you're not even, a part of, right, is going to bring you information, and that conversation has to be able to be democratic in nature and not so autocratic in design, right?
Absolutely. This whole business of, well, where's the evidence? The challenge of changing practice that has to wait until we, generate the article or we've done the research study. All of that will change very rapidly. We're going to see that. I mean, that like a lot of that has to do with AI. The use of AI being able to actually retrieve a lot of that information a lot faster than we are. And so a lot of this is going to happen in real time. People are going to be able to direct their care a lot faster because they'll have more access to more information that's driving their decision making, and that's causing them to come in as more informed people rather than having to be dependent on these systems that have been founded, again, in a lot of the dogma that was around the 19th century kind of medical practice that we established in this country. I'm finishing up the autobiography very slowly. It's a lot to kind of take in. I find myself getting so angry reading parts of it, but the autobiography of J. Marion Sims, because I was interested in all this kind of these feelings and emotions around the father of gynecology and how he used, slaves to really come and develop a lot of the procedures that we use today to treat fistula and these abnormal openings between the anal canal and vaginal canal. And there's just so much emotions, but I wanted to actually read from his own words what he was thinking at the time. And it's archaic for a reason because we want to evolve from that, right? We don't want to just treat people the way that we saw them in 1800s. And I think the only way that that's going to change is to give people the information, is to actually make patient-centered care around the person who has the information. And we're basing our practice on their information, not ours. Ours are locked away in journals. Ours have been decided that it's going to be what we publish and what we put out to the world and what we teach in our universities. We're not using people and their information and patient-centered care to really drive our practice. And I think that's going to change very rapidly in our lifetime.
Yeah. spoiler alert, because one of the rabbit holes I did get down was reading it from cover to cover. And so it doesn't get better.
It doesn't get better, please. Oh,
it doesn't get
goodness.
any better. And if you want a sort of companion read to that, go back and look at all of Samuel Cartwright's work in the New England Journal of Medicine. And
Okay. He
yeah,
references him so much.
exactly.
So
And there's
yeah.
there's a lot there. They were
That's okay.
contemporaries, and there's an
Hmm.
interesting dialogue between the sort of what they called the field practice in Alabama at that time and the burgeoning medical education practice in New York, and there's so much there. And I actually, because was our first documentary, talks about all this, and this is so deep dive into the work that we did. And one of the pieces that was sort of the most startling was fast forward to 2016, and fast forward to a study that was done that found that the average white medical student still held the belief that pain was felt differently amongst different patients of different race, right? So that if you want to say, yes, this is all so archaic and this is all so 200 or 150 years ago, whatever, um it's not, though. And that's the biggest piece of it for me, is that these sort of what we would now call antiquated and archaic notions of the difference in the actual physiology of people, between the races, still informs medical practice. And that's a really big piece of it, right? That is and I remember just I could go through the stories of crazy things I heard in the weeks that I was in the hospital before my daughter was born, and the assumptions that were made, and all kinds of different things, because this is still such a part of it. And I think if we don't understand how deeply rooted these archaic notions are in current practice and current perception and even current actually diagnostic tools, then we're not really scratching the surface. But yeah, it's a lot. And yeah, you do have to sort of step back, because it does produce anger. And then as a patient, and as someone who's saying you've been in the situation, and you realize, like, that's why that happened to me, right? And there's such
Right.
a it's there's so many different things. But yeah, I think the idea of informing oneself and taking that information as being armed is such a huge perspective of it. But yeah, so I'd say, keep reading, but it doesn't get better. It's really my whole thing. um so I just kind of want to talk a little bit. We kind of talked about what you're doing, and so for those listening, how do we find you? How do we read this manual that you wrote and watch some of these videos, and where do we find you? And we'll definitely put all of the actual links and stuff in the episode, but just kind of tell us a little bit about where you can be found, what people, if someone is looking and saying, hey, I'm still 3 years later feeling this way, like, who do they call? What do we do?
Yeah. So I developed the pelvic health network because it's really for me, it was imperative that I develop almost this kind of web of information to inform myself. So it actually started very much like, well, it was not a media farm. It was more of how could I create a network of individuals, of organizations, of people like you that I could have these conversations with, and just inform myself of how big this issue was. Because I was going into it from a rehabilitation lens, a very small, narrow area of practice that most people are really not familiar with, unless your father has a knee replacement or something like that. And so we're not really on the maternal health care team around the country. We just don't exist. And so the pelvic health network was a way for me to just get connected with people who knew, so that anyone finding me, because for whatever reason they believed, that was something that could have helped them. They had a cesarean hysterectomy, and unexpected removal of their uterus at the time of birth. What could they do, or what could they receive in the hospital to help them recover? That's where people primarily find me now. Is enhanced recovery after delivery. Pelvic Health Network is really just the bigger network of individuals that's helping me improve the services that are being offered, at least from a rehabilitation and recovery standpoint, in the hospital and in the home. And so now we've kind of created this spider web, if you will, which there's an Ethiopian proverb about a spider web is can be strong enough to catch a lion. And I had that kind of notion that I didn't want to start any practice ever as an island, as here, come to my island and you'll find all these resources. I want it to be interconnected and interwoven in communities that already existed. And so people can find me there. People can find me under Enhanced Recovery and Wellness. That's kind of like my home, my website home for all the things that I do. And then on YouTube, all social media handles just by my name. And so I'm really just learning. I think the manual is unique because it's not a static book. I don't find that those are helpful because, like you said, by the time you've are done dotting the final I, they're outdated. Mm-hmm. And so I wanted something that was a living manual, a library, if you will, of resources. So the manual is called the Acute Care Obstetrics Rehab Manual, and it's primarily to inform rehab therapists like myself who want to be a part of the team that someone has to improve their birth experience. But instead of being a static manual, it actually is a portal into a library. And so there's interviews, there's people's experiences that are informing providers. And that's kind of the shell of the work, is that there are case studies in there that happen to real people, and it's informing us going forward of how we can improve those experiences. I'll be honest, and this is a cautionary for anyone who wants to read the manual. Not all of it is, I would say take into account that not everyone's experience is someone who's going home with a baby. We have experiences where people have lost their baby. We have experiences where people encountered a surgeon who was pushing too hard for a C-section and they nicked an artery, and that person lost their uterus. They had a hysterectomy that was unexpected because of medical error. So you're going to find cases in there that hit a nerve. And so I just say, we're using people's stories to inform us going forward, but it's not an easy read. It's not an easy manual to inform practice, but it's a necessary one.
Okay. Well, thank you. So we'll make sure to share all of those links with the audience. And I think there are a myriad of topics I could probably talk to you all day about, but I won't continue to keep your time. So thank you so much for taking the time to chat with us, and wishing you a very happy holiday season.
Thank you. This was a pleasure. Thank you. Such an honor.
Dear listener, thank you for joining us again today. It's been a pleasure. As always, we look forward to hearing your thoughts and questions and comments. We can be reached on our website, www.alltheunexpected.com, one word, or via any social media, Facebook, Instagram, even Pinterest. Thank you so much for listening, holding you all in love and light, and have a wonderful week.